I'm Dr. Boardman, and welcome to my session called The Basics of Buprenorphine. This is my potential conflict of interest slide. I do some work for Purdue, Indivior, and AstraZeneca, and so what you'll see from there is Indivior is a company that makes Suboxone, buprenorphine/naloxone, and Purdue does some of the painkillers. So I do work on both sides of the fence of companies that have addiction and have pain. Here's a list of the objectives for today, and we have all 6 of them. The way I've done this talk is I've actually broken it down 1 through 6, and I'm going to handle them one at a time. So I'm not going to go through naming each of them right now. So here's objective number 1, to describe the pharmacology of buprenorphine/naloxone. First, we need to go back to our first-year pharmacology classes and think about what an agonist is and what an antagonist is. So, as you know, an agonist is something that will bind to the brain receptor and activate the cellular signal fully. An antagonist is the opposite. It'll bind to the brain receptor, but it blocks others from binding and it does not activate the cellular signal. Buprenorphine is a little bit different. It's something we would call a partial agonist, and that's something that's going to bind to the brain receptor, and it is going to activate the cellular signaling, but only at a fraction of 100%, so that not fully activated. And we're going to talk later on about how this really can be an ideal thing in the addiction world for people who have opiate dependence. Now, buprenorphine naloxone can be a confusing combination. Let's take a look first at buprenorphine. Buprenorphine, as I just talked about, is a partial mu agonist. There's something else that it does, and that's a kappa antagonist, and that may help with depression. There's only a few studies on that, and most of it's done in animals, but it is postulated that it can make people's mood better. Now let's look at naloxone. Naloxone is a mu antagonist. This can be confusing because I just talked about buprenorphine being a partial mu agonist and naloxone's a mu antagonist. But now look on the next slide how it works. If people take this pill under the tongue, the naloxone should remain silent and not have its mu antagonism activated. If people inject this, then the naloxone can start to be activated and put people into an acute withdrawal. Some people learn well from pictures, and this is a slide that explains something with those 2 pictures on the right. If we take a look at the first picture, be it heroin, methadone, oxycodone, or any of the other full agonists, when they bind, you see all those stars under there. Let's call that dopamine release or full agonism. If we take a look at the picture on the right, we see that the buprenorphine will bind, but the amount of those stars underneath is only a fraction of what the other full agonists do. Now if we look at the next slide, similar pictures, but just the writing on the left-hand side. Buprenorphine has a very high affinity for the mu receptor. So it will displace most other full opioid agonists, such as heroin, oxycodone, methadone, hydromorphone, etc. Interestingly, it may not displace fentanyl, and it also dissociates very slowly from the receptor. This can end up being an ideal thing that we'd want when someone's being treated for opiate dependence. We want something that will bind very tightly and come off very slowly, but not have a full effect. The other thing that it says here, it has a low intrinsic activity, and it has a ceiling on its agonist effects. And I'm going to talk a little bit more about the advantage of that ceiling effect later. Now let's look at objective number 2. Let's discuss the dosing strategies for initiation and stabilization of buprenorphine/naloxone. So prior to the introduction, it's best to have some sort of structured approach, and we need the ability to stabilize as rapidly as possible. And for those of you who know a lot about methadone, you know that we start low, go slow, but we really want to stabilize people rapidly on buprenorphine. And we do want to avoid oversedation and precipitated withdrawal, and I'll talk about these things, but to be honest, they really are quite rare in the induction of buprenorphine. I have written there informed consent on page 90. That's 90 directly out of the buprenorphine guidelines from the Center for Addiction and Mental Health. It just allows you to make reference to that. Some of the tips that I've learned over the years are that we want to discourage any sort of induction where we might not be able to clinically assess people for a day or two. So I like to do mine on Monday or Tuesday, and that gives me a few days. If no one's going to be around, or it's just skeleton staff at your pharmacy and the doctor's not available, I hesitate to do something on a Friday and have limited availability to troubleshoot on Saturday and Sunday. It's good we have urine strips that will tell if people are on buprenorphine. I like to do that just to make sure that they aren't getting it from another doctor or if they've tried it from their family or friends. And if they have, that's a conversation that needs to be had before I write my first prescription. Women of childbearing age should have a beta HCG, and we should not start them on this medication if they're pregnant. However, if they're on this medication already and then they get pregnant, that's a whole other kettle of fish that we need to switch them to different things that's handled in other talks you'll see on the website. And I like to discuss driving restrictions for people. Anytime we're changing a medication, giving a new opiate, even though this is a pretty safe one, we really want to make sure that they have somebody driving them for the first couple days till they're stabilized. As I stated before, this opiate can be different than all other opiates in that we want to induce rapidly. And if we start too slowly, patients probably will feel sick and decide that this medication didn't work and it's not for them, and that's a shame. So we really want to induce rapidly. So let's take a look at induction day. Patients need to be in mild to moderate withdrawal. You will sometimes hear doctors saying they need to be in severe withdrawal. I feel that's incorrect. If you put them in severe withdrawal, you can run into all sorts of other problems. They need to be ready for their next dose of their opiate that they would normally take. So I'll monitor them to ensure that they have some withdrawal. However, if their greatest withdrawal is something like anxiety and they're already on a benzodiazepine, I want them to take the benzodiazepine. I don't want them to hold back on that because I don't need them to be in benzodiazepine withdrawal. But they just need to be ready for their next dose of opiates as if they're in some mild to moderate withdrawal. We need to make sure they're taking it appropriately, and it's good for pharmacists and doctors to work together and be educated to know that the patients have to keep it under their tongue, and the sooner they swallow it, the less effective it will be. And again, if they're having withdrawal symptoms, we can manage it. If people are worried about having diarrhea, we can give them an anti-diarrhea medication. If they're nauseous, we can give them something for nausea. They can have anti-inflammatories or plain Tylenol for their pain as well. This slide shows a clinical opioid withdrawal scale, or a COWS scale. While I do use it, I realize it has its limitations. As I mentioned before, if someone has a lot of anxiety from opiate withdrawal, but they're taking an anti-anxiety medication, they may end up scoring a 0 on this, but I know that really they might be in more withdrawal than the scores on this have. So use a scale, but don't worry if you get a low number because people are being treated with other medications that may help treat some of these conditions. Now let's take a look at induction dosing. So the day 1 target has actually just recently changed. It says 4 to 8 milligrams. Just recently, the new product monograph came out, and we can give 12 milligrams in the first day if needed, but well over 90% of my patients are still getting 8 milligrams usually. I give them 4 milligrams when I first see them and they're in some withdrawal, and then I check them an hour or two later and I see how they're doing, and I either give them another 2 to 4 milligrams if they need it, or perhaps wait till later in the day. If you're working in a hospital and you're doing in-hospital inductions where patients are being monitored, you can do this a little slower than what I've mentioned. But if you're doing it as an outpatient, there's a practicality to how long a patient has to stay around in the doctor's office and in your pharmacy. So that's why I've adapted it to giving them 4 milligrams right away, reassessing them in 1 or 2 hours, and making my decision for the rest of the day. When they leave my office, I usually have made a follow-up appointment for the next 1 or 2 days. That's again why I usually like to do a Friday induction. And the patient leaves with a prescription for the additional dose of buprenorphine, and I'll usually speak to the pharmacist about it. So let's say we gave him 4 milligrams. I'm going to give him another script for the extra 4 milligrams for that day, be it observed by the pharmacist or perhaps to take home later. And I'll give them a prescription or suggest some medications, as I say, for those other symptoms that they may feel. And either I'll give them my after-hours contact information, or I'll tell them that I'm going to call them later in the day just to see how they feel. The reason for that is sometimes patients don't feel great on the first day, and I don't want them to drop out of the program because generally they're going to feel really good by day 2 or day 3. So sometimes a call later in the day can really help them stay in the program and realize that this is the best thing for them. Here's a very simple sample schedule of day 1, day 2, and day 3. And as I say, I've just recently adapted this to give up to 12 milligrams on the first day as per a brand new product monograph. And if I've given them 12 milligrams the first day, I may give them up to 20 or 24 on the second day. But the fact of this, what I want to show you, is if you think to methadone or you think to morphine or hydromorphone, start low, go slow, and it can take weeks till someone's at a steady state and feeling good. You can really feel good on buprenorphine by day 2, day 3 at the latest. And I really try and stress this when patients are making up their mind as to whether they want abstinence-based therapy or methadone or buprenorphine/naloxone. So this to me is a very big advantage. If patients can understand this and learn about this, that they'll be better within a day or two. Now let's take a look at objective number 3. We're going to look at some common drug interactions, contraindications, adverse effects of buprenorphine, and we'll look at precipitated withdrawal and its management. So this is a very busy slide, but if you look at that first thing, headache, over the last 8 years or so since buprenorphine has been available, I would say that's the one thing that I've seen more often with this opioid than the other opiates, is people complain of headaches. But I've yet to have someone have persistent headaches past a few days or at most a week to 10 days. This usually settles down. It can be quite a hindrance if someone's come in having a problem with opioids and the reason they got on opiates was for migraine headaches, and I tell them they may get a bit worse in a few days, but I do talk them through that. So again, headaches is the one thing. A lot of these other more of a class effect, and even the second one, withdrawal syndrome, a lot of times that's because we've asked people to come in some withdrawal, and if we start too slowly they'll persist with withdrawal, and that's not necessarily from the buprenorphine, it's from our treatment. But nevertheless, as I say, headache is the one that I do mention to people may be a little bit more common. So let's look at precipitated withdrawal. And this is a thing, to be honest with you, that when people train a day in buprenorphine, this really scares them. They really feel that they're going to make people a lot worse by causing a withdrawal symptom. Over the years, I found this is much rarer than you would think. And I've only had a few patients that have had this, and I'll talk about where I've learned from this. I have a diagram on a slide or two about how this happens, but we give a partial opioid agonist and the patient's fully dependent on the full agonist, and in comparison, that partial agonist just doesn't feel strong enough and it makes them feel like they're having some withdrawal. The main risk factor is a short interval from the last opiate injection. Or, as I've seen that's happened, not every patient tells me the truth, and sometimes people are wearing a fentanyl patch or even chewing a fentanyl patch when they've seen me, and they will start to possibly feel some withdrawal if we give them buprenorphine. So that's been one of my main things. But generally, we say it's from not a long enough time. But you don't want to go too long because you don't want them to have severe withdrawal and then you're trying to catch up. So once again, if people like pictures, here's a picture on the right-hand side that shows heroin, and that could also be oxycodone or morphine, and it's causing that full effect. And if it's sitting on the receptor and then the blue thing in the second picture, buprenorphine comes and knocks off the orange full agonist, only a partial effect may cause some withdrawal symptoms. But if we do it properly, like on the third picture there, if we wait about 6 hours after the last heroin use, and 6 hours, if you notice, that does not say 24 hours or 36 hours, just about 6 hours, there's going to be an empty receptor, buprenorphine's going to come on it, and it's going to make people feel better. Sometimes pharmacists and doctors ask me, how can I explain this very simply to patients? And the way I explain it to patients is, I say that very first dose of buprenorphine is going to make you feel the opposite of how you're currently feeling. So if you feel that you have empty receptors and you're feeling a bit lousy and you really wish you could have some opiates, the buprenorphine is going to come and sit on that opiate receptor and make you feel better. If you feel that you needed to take something before you came and saw me and you're actually feeling quite fine, you've just recently had some heroin or just had an oxycodone pill and you feel fine, the buprenorphine is going to knock that off its receptor and make you feel sick. So hopefully that's a good practical tip for you in your pharmacy. That first dose of buprenorphine is going to make you feel the opposite of how you're currently feeling. That doesn't mean all subsequent doses are going to act like that, but the first dose is how I explain that to people. So what can we do with precipitated withdrawal? So we can treat supportively. They can have something for their withdrawal symptoms. We could retry the buprenorphine in 1 or 2 days. Another thing that I've done lately in my teaching is, especially now that we can give people up to 12 milligrams, is sometimes I do now suggest to people just push through it and give a higher dose of buprenorphine and go up to the 12 milligrams. And eventually those other opiates are going to come off the receptor and people will feel fine. That's relatively new, but sometimes people stop and want to try in 1 or 2 days. The other thing I try and do is I try and learn from the experience. Where have I ran into trouble with people having some sort of withdrawal symptom? I have some slides later on the difficulty of switching people from methadone to buprenorphine. I mentioned fentanyl already, and especially if people are not being truthful. Part of the problem with fentanyl, if they're using a patch, we don't know how long the fentanyl lasts under the skin in that skin reservoir. And also fentanyl also has a very high affinity for the opiate receptor, just like buprenorphine, so that creates some unique issues. I've learned from the timing, but generally what I found is you don't need to have people in 16 to 24 hours of withdrawal. That's overkilling it. And the main thing I've learned from this is about some health issues that some people have had. I've had people who've had, say, a stomach ulcer, and when they got a little bit nauseous, that stomach ulcer flared up and they started to have some intractable vomiting, and they actually had an obstructive stomach ulcer, had to send that woman to hospital. That the buprenorphine withdrawal that caused it, it didn't cause it, but it did seem to cause that final little hump that this event of having an obstructive ulcer that was maybe going to end up in the hospital a few weeks later ended up in the hospital that day because she started to feel nauseous from the withdrawal. So once again, if this happens, try and learn from your experiences and discuss these with your colleagues. What are some contraindications to being on buprenorphine naloxone? Pregnancy is a contraindication to starting this treatment, and that's really because we've never proven that naloxone is safe in pregnancy. However, we've never proven that it's not safe either. So if on it and they get pregnant, we do have to handle it and rotate them over to buprenorphine alone and get that from the drug manufacturer shipped up from the United States. But we wouldn't start somebody if they're pregnant already. People can have an allergy. There can be some liver dysfunction. It really needs to be severe liver dysfunction to consider it. I do have people who have elevated liver tests and hepatitis C, and they've failed on methadone, or they don't want methadone, or they're going to have cardiac abnormalities with the methadone. So I have given it, but that's more of a relative one. And some of these others that you'll see are more a class effect to opiates as opposed to being specific to buprenorphine. Objective number 4. Let's compare and contrast properties of buprenorphine naloxone with methadone when used for the opiate substitution therapy. So what are some properties of a good opiate agonist treatment? And that OAT, you could put in, substitution treatment or medically assisted treatment. I sometimes call it different things. We want something to be safe. I think in 2016, moving on, we're really striving for what's the maximum safety. And basically, I generally feel that buprenorphine naloxone is safer. Ease of initiation is something that we want to take a look at. And the ease and speed of buprenorphine is greater, but people do need to prepare by not taking something for a few hours. So sometimes when I'm seeing somebody right in front of me, especially if they're very anxious, especially if they're very ambivalent to treatment, if they've just taken something and I say, well, you'll need to come back tomorrow to start on buprenorphine, but I could start you on methadone today. So sometimes methadone's easier because you can generally start on them that day, but hopefully people can see that there are some other benefits, and if they start on methadone that day, they still might not be at a steady good dose for 6 or 8 weeks, but buprenorphine, they'd be at it for 2 or 3 days. But we are dealing with people who have an addiction problem with ambivalence to treatment, so they're not always thinking as rationally as I made it sound just now. We'd like people to be able to taper off a medication easily. Generally speaking, buprenorphine naloxone is an easier medication to taper off of than methadone. And I say that generally, but not an absolute statement. Cost can be a big factor for people. So methadone through a month is probably cheaper than buprenorphine. Methadone is covered on the Ontario Drug Benefit, and Suboxone is covered by limited use. And stigma is a big factor. And a lot of people have come into my clinic and say, I would not be here in a million years go on methadone, but I will go on buprenorphine, and I fully respect that from people, that if they feel a medication stigmatized, I can explain it, but I will respect the fact that they may not want to be on it. Being a partial agonist, and it has a safe ceiling. So if you look at the picture, that dashed line is a threshold for respiratory depression in an opiate-dependent person. The first line that goes up is a full opiate agonist, and as you can see, a full agonist can exceed the threshold for respiratory depression. That middle line is buprenorphine, and it goes up at a slower rate and looks like it's a full agonist, but it hits a ceiling effect, and that ceiling effect in an opiate-dependent person is below the respiratory depression threshold. That's very important. What do our patients die of from opiate overdoses? They stop breathing. So this is something that helps prevent that. Now, that dashed line is there and above the limit for buprenorphine, but if people take alcohol or benzodiazepines or maybe lots of muscle relaxants or have severe chronic obstructive lung disease, that threshold may end up being lower. Or if it's a child who's accidentally taking his parents' 8 milligram buprenorphine naloxone pill, then they certainly could still overdose. But in your average opiate-dependent person who isn't on benzos, this is a very hard drug to accidentally overdose on or even intentionally overdose on if it's just isolated buprenorphine. And to me, in 2016 and beyond, where we're very worried about safety, this is the number one factor as to why I really stress to patients the importance of giving a try to buprenorphine before they try methadone therapy. So as I talked about, the use of buprenorphine with alcohol and other CNS depressants is something that we need to be cautious about. It can be fatal. I'm going to show you some things later about good studies done with lots of patients in France in the 90s and 80s, and it is important, but it's important as a class effect also for all opiates. All people who are taking opiates should know that if they drink alcohol or take benzodiazepines, that they are at a dramatically higher risk for overdose. So now we have a table, and this looks rather busy, and this is from France, done in the mid-90s. France is an interesting country. It wasn't available in Canada back then. So the interesting thing about France is that they knew they had a big heroin problem, and they had methadone clinics, and the methadone clinics were extremely structured, and they were usually tied into hospital settings with lots of rules and all observed doses. And then when buprenorphine came out, they realized they had this problem, and they encouraged all the family doctors, all the doctors to prescribe buprenorphine without much training. This didn't have naloxone in it, so they really didn't care if people injected it. They just knew that this sounds a lot safer than injecting heroin, and the methadone clinics were very structured. A lot of people couldn't get into them or didn't want to. And we're going to compare the death rates to a very, very structured methadone clinic with lots of rules and lots of observation, and a really purely harm reduction treatment of buprenorphine where they knew people were injecting it and things like that. So the numbers there are a little hard to read. I'm going to summarize it on the next slide. So we're going to take a look at deaths attributable to methadone versus buprenorphine in France in this study. So in these years, there was about 1.5 times more buprenorphine deaths than methadone deaths, but there were 14 times more patients who were receiving buprenorphine than methadone. The yearly estimated death rate related to methadone use was at least 3 times greater than the death rate related to buprenorphine. And when you translate this to a volume, patients in France who received either of these drugs would have been treated only with methadone, the expected number of deaths would have been 288 instead of 46. And what I told you a minute ago makes this even more of a staggering number in that the buprenorphine, the docs knew that people were starting to inject it, which is obviously something more dangerous and something that's a little more difficult with the combination product. There was virtually no supervision, no training of doctors and pharmacists. They were just encouraged to write the buprenorphine. Don't worry about it. We got to get people off of their heroin. So these numbers are actually quite staggering when you think about it. Let's take a look at kind of comparing what happens in a clinic. And this was in the United Kingdom, and it's called the Summit Trial. Just taking a look at out in the field, a comparison of buprenorphine and methadone, and what some characteristics were of some patients and some breakdowns they did. Now, this is not a random trial. This is doctors giving informed consent about all the different treatments available and patient and doctor deciding what treatment's best for them. So the participants choosing methadone had more severe substance abuse and psychiatric and physical problems, but were more likely to remain in treatment. Well, that actually makes a lot of sense to me, don't you think? If you started to explain how these things work and you look at some selection bias as to what doctors would lean people towards and what patients may end up choosing themselves, that the ones who had the more severe illness and more psychiatric problems probably did go on methadone and probably did stay in treatment longer. I've heard some people twist this around and say, so buprenorphine doesn't keep people in treatment longer and they're less likely to stay in treatment, so that's a bad thing because we do want people in treatment longer. Those people are correct. We'd like people to stay in treatment longer, but one of the facts that buprenorphine seems to be an easier thing to get off of, and maybe the people choosing it had less severe so they remained in treatment less time. So you really have to be cautious if you make an absolute statement about a benefit of methadone is that it keeps people in treatment longer. Some people on buprenorphine don't need as much treatment, and some people do want to be off treatment, and I think it's nice for us to be able to allow them to choose buprenorphine if that's what they want. One interesting thing is those retained on buprenorphine were more likely to suppress illicit opiate use. I'm not going to make that absolute statement in my practice. I do find methadone very effective to decrease use. I think there's a bit of a selection bias in my practice that the people who maybe don't have severe an illness of opiate dependence may lean towards buprenorphine, and I may lean towards offering them buprenorphine, and those people may also be more likely to be ready to decrease their opiate use. And this last thing that I put in red is something that I find in my practice is more and more, as people know I prescribe buprenorphine, more and more people come in and say, I'm here for buprenorphine therapy. As I said before in this talk, they tell me I wouldn't have stepped foot in your clinic in a million years if all you offered was methadone, but I've heard about buprenorphine, my friends are on buprenorphine, my family's read about buprenorphine, and I'd like to try that therapy. So now let's take another look at safety, and Dr. Lee has written a couple articles, and our patients who have opiate dependence will do things that we don't want them to do. People will divert drugs, they will divert methadone, they will divert buprenorphine, they will divert oxycodones. It's a fact of life. So the patients who divert methadone versus the patients who divert Suboxone and the people who've taken those medications, here's something about the ICU rates, that the rates are much higher if you've consumed diverted methadone than if you've consumed diverted buprenorphine. Just recently, I came across another study from Dr. Lee and a very similar finding about people taking methadone and benzodiazepines unauthorized versus people taking buprenorphine and benzodiazepines unauthorized, that the ICU rates are much higher in the methadone and benzos. So really, from a societal point of view, the more buprenorphine that's out there, the better it is versus the more methadone that's out there. One other benefit if your pharmacy is closed on Sundays or holidays is that once people are stabilized, they don't necessarily need to take their medication every day. Now, as human beings, we're 24-hour creatures of habit. So if we don't do something that we do every other day, we sometimes can start to feel that we might have needed it. So if a patient takes 8 milligrams of buprenorphine every day, but your pharmacy's closed on Sunday, we can give them 16 milligrams on Saturday morning. And if you look at their blood levels, that will last to Monday. As I say, I do sometimes warn people that people are creatures of habit, and not all withdrawal is actual physiologic. A lot of it is mental. So I explain this to patients, but sometimes patients will then say, well, but by Sunday afternoon I felt sick, so I needed to take something. But this can be a huge advantage if your pharmacy's closed or if your patient has to go out of town. They work an extended shift and they're out of town every Thursday or something. You can give them a double dose the day before once they're stabilized, and that should be good. I mentioned before about the difficulty in switching patients from methadone to buprenorphine. And one thing I found with doctors who don't prescribe a lot of buprenorphine but prescribe a lot of methadone is that their first foray into dipping their water in the buprenorphine pool is their methadone patients that want to switch. So that's actually a really difficult switch and usually leads to a bad result in making people feel that they have bad experiences with buprenorphine. But if people want to switch, I'm going to talk about a way to do it. So the most important thing is for everybody to be communicating. Now, if it's my own patient, I'm communicating with myself and the pharmacist. I'll try and reduce the methadone down to 30 milligrams or less, but not everybody can get there. I want to wait as long as they can after having a methadone dose before I start the buprenorphine. What I've started to do now that isn't written down here as much, but if somebody's stable, I will then give them something like morphine for a few days and stop the methadone for 3 or 4 days. But give them something, because I don't want them to go through 72 hours of opiate withdrawal. That's rather cruel and really isn't necessary. And then once they're off the methadone for 3 or 4 days and they've had a couple days of morphine, then we can have them go a few hours without the morphine and switch them over. I've had better results since I've started to do that, but you could just stop the methadone for 24 hours. Someone needs to be extremely motivated to go on buprenorphine. If it's something that a doctor and pharmacist have decided, the patient will probably feel too sick. If the patient is extremely motivated to go from methadone to buprenorphine, they may be able to make it through the feelings that they have. Now let's look at number 5, understand monitoring parameters and identify red flags for buprenorphine. So your best resource for this is the buprenorphine guidelines that are on the website from the Center for Addiction and Mental Health, or you could just go to Google and type in buprenorphine guidelines Ontario and this will come up. They were made in 2011. Perhaps they may be changed in the next year or two and updated, but Dr. Hanford was the principal author, and these really are well thought out, excellent guidelines. I'm going to just talk about what to do with take-home doses of buprenorphine, and again you'll find these on page 40 of the 2011 guidelines. So we divide into 3 categories. Someone's clinically unstable. they're still using other drugs, they maybe don't have good housing, there's people in the house that are bringing them drugs and they're selling drugs still or something, they shouldn't have any take-home doses yet. Then there's clinically stable category A, and they could have weekends and holidays. So once they've kind of stopped using some of their other drugs, they have a sample that's free of any unauthorized drugs, I'll give them weekends and holidays quite quickly. And then clinically stable category B means you're beyond that. You really take a look at their history. They were dependent on prescription opiates from one prescriber. They weren't injecting it. They were swallowing it. They weren't double doctoring 3 or 4 different doctors. The people living in their house are okay. There's no severe psychiatric symptoms like a suicidal depression or borderline personality disorder that is really possibly disruptive to treatment. They're working, and it looks like, geez, maybe if we don't give them some take-homes a little bit quicker, they may have to drop out of the program because of work, family commitments. In methadone, it's much more difficult to do this and document why you're doing it, but in buprenorphine naloxone, you can do this. So there are 5 things that need to be documented about early take-home doses. And this is what I document. I actually have this in my chart, and I put check marks and I put in things there. So the patient should have a satisfactory level of clinical stability. You have to document why the earlier take-home doses will benefit the patient and that they have a low risk of misuse or diversion of the take-home doses. I generally have people sign that they should be made aware that technically in the old product monograph it said not to give anything for 2 months. Now we can give things within 2 months, but I still let people know that I am accelerating your take-home doses, and I sometimes have people initial right here so that they know that they're going on an accelerated program. And I think that can be beneficial to them to know that I'm doing that. Generally, it's good to increase gradually. So we can take home doses after a couple weeks. Then I tell them every week or 2, I'm going to increase another day per week. So 3, then 4, then 5, up to 6, as opposed to just right away giving it all at once. But that's a general statement, not absolute. If someone's going away after a few weeks and I've documented why they're going away, I will give them some. In methadone, that's very difficult to do, but here in the buprenorphine naloxone world, I do. And I document all this in the clinical record. And as pharmacists, I think that's a good idea for you to document that too, that you're aware, that the patient is aware, that they're getting take-home doses a little quicker than they should be, and that you've also documented to make sure that they keep them locked away, make sure there isn't a 3-year-old at home. This pill is left on a table. A 3-year-old could certainly accidentally overdose on it. So you just want to make them aware that this is happening a little quicker and that things are safe. Now let's take a look at objective number 6, and this is our last objective. So what are some common challenges and barriers encountered with buprenorphine naloxone when used as part of the opiate substitution therapy or medically assisted treatment programs? So I'm going to talk a little bit about medically supervised withdrawal. So there really isn't good scientific evidence that getting people off it is effective. Patients are at a higher risk for relapse when they get off this and go through withdrawal. And the amount of opiates that are out there now, oxy 80 milligram pills, fentanyl 100 microgram patches, if people lose their tolerance, they're at a very high risk of overdose if they relapse. So we really need to be cautious with this, that this is a chronic illness. Patients are prone to relapse. So let's please help our patients and make them aware of this. But if decide to take this approach and want to taper down, then usually tapering down by 2 milligrams